So you've talked before about the quality continuum as a spectrum of compliance and continuous improvement. What do you see as the role of regulators in this continuum, and what should providers be doing beyond just ticking the boxes?
Yeah, I think quality is tricky because it's a pretty broad concept, and I think regulators are increasingly understanding that, and so they are looking for quite different bits of information in order to build a full picture of how providers are doing. Um, Something like quality indicators, they're sort of serving. Let me think how to phrase this. A regulator is sometimes serving multiple purposes. So they're serving the needs of what is a significant payer, typically your government and your taxpayers. They're serving the needs of the people receiving care. And then to some extent, they're supporting the providers to get better and provide better care. Those goals can sometimes work together really well, but other times there's a differing view on what constitutes good quality. So almost anyone that interacts with healthcare or social care, they will view good care as good outcomes. Most people delivering care will view good care as good practices and process. And then the payer will generally look to optimize both, recognizing that sometimes those things don't necessarily go hand in hand. So it's difficult, but I think by tracking multiple bits of information across things like feedback, improvement activities, audits, you can build a fuller picture, and I think regulators are doing that.
It's interesting that you bring up the subject of who's paying, because in the UK we have huge pressure on social services budgets at the moment, and the hourly rate that some of them are prepared to pay providers is quite shockingly low.
Yes. Yeah.
Where does quality sit in that spectrum, really?
Look, it's an uncomfortable conversation, but people, we have to have a conversation about how much we're willing to pay and what sacrifices we're potentially willing to make to other spending in order to get care delivered to the standard that we want it to be. There's no getting around the fact that, good care costs money. And so like with any kind of expenditure, it needs to be rationalized in terms of how much we're spending and how much value we're creating within that system. I think there's a very strong sort of moral imperative in social care, but we also need to recognize financial constraints, and so how do we deliver optimally in those systems at low cost.
And to put my marketing hat on, having chatted to different providers that have used systems like CareLineLive and MOA, they are saying, well, we are saving time in terms of staff time, whether that's office-based staff or carer staff, because of the efficiencies that the software can bring.
Yeah, that's right. I mean, manual processes, manual writing of audits, manual documentation, those last minute scrambles can cost an enormous amount of money in terms of preparing for an inspection. We also see the UK tends to have a little bit of a reactive approach to waiting until they'll get some feedback and then remediating a problem, right? And so the cost of remediation of any sort of problem in care tends to be quite high. And so it can be difficult to rationalize, well, we're paying to prevent that problem that you'll remediate later from occurring at all. And so that can be difficult because it's viewed as expenditure now. But operationally, there certainly can be savings if, people are required to maintain these systems and maintain audits and tracking and Excel documents and then bring all this information together. There is a cost to that, and I don't think people necessarily fully appreciate that there is a cost to maintaining all those things.
For the three kind of areas of care, home care, retirement living, residential care, where are they in terms of quality and compliance and their use of technology? Are they all at a similar level, or do you see differences between those three areas?
All very different. So retirement obviously is effectively independent living, and so there's the focus, to the extent that there is a focus on quality, it's focused less on care and more about experience. And so, if we talk about the old sort of framework of quality from Donabedian, the structure, process, outcomes. Outcomes often includes experience. Sometimes it's added its own domain. So it sits in that experience domain. These are typically able-bodied, independent people. What we are seeing, though, is increasingly retirement living providers are also acting as home care providers within their retirement villages. And so this now opens them up to potentially the quality approach in home care. And so are we delivering the care and supports that people need to a high standard? Home care is obviously really tricky because you've got a decentralized workforce providing care in other people's homes or in retirement villages. And so it can be really difficult for those process things because there isn't the capacity or power to observe how care is delivered. And so, yeah, it will focus a little bit more on documentation and that the process of care in terms of documentation is correct. Residential is the most sophisticated. Obviously, we've seen an increase in acuity typically of people entering. So people are entering later in life at higher acuity. And so they are becoming, quite clinically focused in terms of, medication, you can have dialysis. So, they're much more sophisticated in terms of that captured environment in terms of, and there's more. So in a residential environment, there is, an accountability to outcomes when you're dealing with a home care client that potentially is only seen a few hours a week. To what extent is the provider accountable for adverse outcomes? To what extent is their local GP responsible? To what extent is there other supports that they might use responsible? So that attribution problem, when you're asking about what the quality of service is really challenging and really difficult to unpack. And it's something the Australian government is struggling with at the moment because they're looking at how they might be able to introduce something similar to the National Quality Indicator program we have for residential into home care. And it's going to be very, very challenging to do that because of that attribution challenge.
Do you feel that there's a tension between what care providers are focused on and what care recipients would like to have be emphasised?
Uh, Probably, yes. I mean, I think I alluded to it a little bit before in the sense that people receiving care tend to be very focused on outcomes. And experience, right? So am I having a good experience of care and did I get my desired outcome? And so that, in a residential care, if I look at feedback, the most common feedback for people using MOA feedback and complaints is around food. So food is a big part of their experience, right? In terms of living in an environment. If I went through and looked at where the quality improvement activities were in a care home, I can guarantee that will not be the highest category of where they're drawing their attention. And so they're much more clinically focused. They'll tend to be much more process focused on how they deliver care, less focused on probably the things that are coming up for residents.
So you mentioned Donabedian.
Yes.
Okay. The framework there. Do you want to walk us through that in a little bit more detail and explain why it's still so relevant such a long time after it was developed?
Yeah, so it's I don't know, it was a Hungarian potentially, but physician that emigrated to the United States. He proposed a framework by which we could consider measuring quality. And so he came up with these three domains, which are structure, process, and outcomes. And so structure includes things like the physical equipment required to do my job, but also people. Do people have the right skills, qualifications? Do I have enough care minute time available to me to deliver the type of care I want? So that's sort of the structure piece. The process piece is, am I doing what I'm supposed to be doing effectively? Is what we are doing aligned with what we know to be best practice, aligned with our policies. So there's that process piece. And then the outcomes piece is, Are the people receiving care happier? Do they have less adverse events? That end of the spectrum. And so providers tend to, if I'm looking at a really macro level, if I'm looking at government level, they'll focus on things like care minutes. And so they're in the structure. And then the providers themselves and care workers will tend to focus on process. Oh, I've done what I'm supposed to do. The outcomes I can't control. And then people receiving care tend to focus on outcomes. Outcomes broadly considered to include experience, but sometimes referred to as its own domain. And so that's, things like satisfaction surveys and the like.
And how would you respond if a provider says, well, we did everything right, but we still had a poor outcome?
Well, that is, of course, possible. And so one of the things that we do at MOA is how do you make outcomes comparable after considering differences in the people receiving care? Because what drives different outcomes, despite following the same process, is going to be variability of the individual person receiving care. And so we focus on case mix adjustment or risk adjustment to better allow for those comparisons to be made fair. So we've built out a few models already that are predicting what is the expected probability, because I know this person has a different risk profile to this person. And then we can use those data to compare to what actually happened after accounting for all those differences at the individual level. And we can come up with a much fairer comparison and say, well, yes, you did have worse outcomes, but that's explained by the fact that you have much more complex people that you're caring for.